the annual conference of IAP, Dr. C. Thirugnanasambandam Award. To judge this award, we have three renowned judges: Professor Dr. Nedunjerian, former HOD Department of Pediatrics, Dharmapuri Medical College, and Director Head Academics, Mehta Multispecialty Hospitals. Professor Dr. S. Ramesh, former professor in HOD, Chidambaram Medical College, and Dr. Sridevi Narayan, Professor of Pediatrics, Institute of Child Health. Dr. C. Thirugnanasambandam, popularly known as CTS, was a legendary figure in National Pediatric Circle. He succeeded Professor S.T. Archer as the second director and superintendent of the Institute of Child Health and Hospital for Children, Egmore, the post which he held for 11 long years, a unique distinction which he alone possessed until all directors until date. He served as the president, Tamil Nadu State Chapter of IAP in 1976. To honor his great services in the field of pediatrics, the IAP instituted Professor C. Thirugnanasambandam Award at the state level. This was established to honor this legendary figure. Guidelines for the CTS award. One award for the best paper in gender pediatrics, including neonatology, will be given during the zonal conference of IAP. Each presenter will be given 10 minutes for presentation and 5 minutes for discussion. The question will be from the judges only, and the answer will be from the presenter only. So the first presenter of CTS award, Dr. Abhinaya, efficacy and safety of low-dose midazolam and ketamine for sedation during pediatric invasive procedures in a resource-limited setting. Over to Dr. Abhinaya.
Good morning, one and all present here. I am Dr. Abhinaya. I am here to discuss the study of efficacy and safety of low-dose midazolam and ketamine for sedation during pediatric invasive procedures in a resource-limited setting. So we'll discuss under the headings of introduction, aims and objectives, materials and methods, results, discussion, conclusion and recommendation. So coming to the introduction part, in recent days, it has been noted that there is an increase in the invasive procedures performed on children. Procedural pseudoanesthesia reduces pain and anxiety among them. However, in a resource-limited setting, various factors such as financial constraints and availability of anesthesiologists for providing procedural sedation becomes difficult. This can be overcome by combined use of low-dose sedatives outside the operating room by a pediatrician or a clinician who have been trained in PALS without compromising the comfort and safety of the children. By doing this, it will be cost-effective. It also increases the success rate of the procedure and prevents delay in providing appropriate treatment. The aim of the study is to assess the efficacy and safety of administering low-dose midazolam and ketamine to children undergoing invasive procedures by non-anesthesiologists outside the operating room. And the objectives were to know the effectiveness of low-dose sedation through successful completion of the procedure, and also to determine the incidence of adverse effects associated with low-dose sedation. Materials and methods. It was a prospective observational study done in a tertiary care center, either in a PICU or a high dependency unit, during a duration of 18 months, that is from December 2020 to May 2022, with a sample size of 165 invasive procedures. And the inclusion criteria were children between 1 to 17 years who are undergoing invasive procedures like diagnostic LP, intrathecal chemotherapy, bone marrow procedure, or a combination of these were included. In the same patient, repeated procedures at different occasions were considered as separate events. And the exclusion criteria were child on cardiovascular or respiratory support, child with altered sensorium or raised ICT, and children who have experienced major complication from previous IV sedation. So coming to the methodology, after applying inclusion and exclusion criteria, children who are recruited are prepared for procedure. That is, informed consent was obtained from the parents. Then the child was kept fasting 4 hours for liquids and 6 hours for solids, and continuous vital monitoring was done by a staff nurse at the bedside. Since most of the patients were oncology patients, each children were pre-medicated with an antiemetic. After doing this, emergency equipments were kept ready at the bedside. After this, pediatrician or a clinician or a pediatric internist trained in PALS will administer sedation. Midazolam and ketamine was administered. The usual recommended dose of midazolam was 0.1 mg per kg and ketamine was 1 mg per kg. But we chose to give 50% of the actual dose, that is midazolam of 0.05 mg per kg and ketamine of 0.5 mg per kg. Our main intention was to minimize the incidence of adverse effects, especially in a setting like outside the operating room. After this, continuous vital monitoring was done during and after the procedure, and the sedation was assessed using modified Ramsay score. And this is the modified Ramsay score, which is a sedation score which is graded from 1 to 6, and a sedation score of 5 or more is considered as satisfactory. That is, 5 is slow or incomplete reaction to painful physical stimulation, 6 is no reaction to painful stimulation. So any score less than 5 is considered as not satisfactory, and further doses will be required in such cases. So after preparing the patients, first aliquot of midazolam and ketamine as per dosages explained before was given, and Ramsay score was assessed after 3 minutes. If the score was 5 or 6, then the procedure will be continued and completed. But if the Ramsay score was less than 5, for say score is 3 or 4, either midazolam or ketamine second aliquot will be given. But if the score is 1 or 2, both midazolam and ketamine will be given. After 3 minutes, the Ramsay score was reassessed. If the score was 5 or 6, the procedure will be completed. If it is less than 5, either midazolam or ketamine will be given in case of score 3 or 4. In case of score 1 or 2, both midazolam and ketamine will be given. After 3 aliquots, the procedure will be completed and monitored for adverse effects. So in our study, 70 children met the inclusion criteria, out of which 8 children's parents were not willing for the study and 4 children were on cardiorespiratory support. So after making necessary corrections, 165 procedures in 66 children were finally enrolled, out of which 39 were boys and 27 were girls. So this is the pie chart showing the invasive procedure. The most common invasive procedure done in our study was lumbar puncture with intrathecal chemotherapy, which accounted for 75%, which was followed by bone marrow study, that's for 20%. Then the combined procedure, that is bone marrow study, LP with intrathecal chemotherapy, which accounted for 4%. Last comes the lumbar puncture only, that is 1%. So coming to the results, this table shows the response to sedation with each aliquot. About 66% of the procedure was completed with the first aliquot, and 32% of the procedure was completed after second aliquot, and 1.2 procedure was completed after third aliquot, and 0.6% of the procedure was not completed even after the 3 aliquots. So this table shows the overall adverse effects. About 84% of the procedures were not associated with any of the adverse effects, and remaining procedures were associated with mild to moderate adverse effects like vomiting, headache, fever, pain in procedural site, hallucination, and with the exception of one child had desaturation. So that child was managed with oxygen support for a brief PICU stay, and there was no life-threatening events or mortality documented in the entire study. So, and adverse association of adverse events with each aliquot of sedation was studied. So there was no significant association with either first and second aliquot of sedation was noted. But with the third aliquot, there was a significant p-value of 0.01. That is, of the 3 procedures which required third aliquot, adverse events were noted in 2 procedures. So association of underweight with procedural success with first aliquot was studied. The first column shows the underweight children. The second column shows the other weight band children. So nearly 44.4% of the underweight children was successfully sedated with the first aliquot, and 55% required further doses. In comparison, the other weight band children, around 72% was successfully sedated with first aliquot, and 27% required further doses. And there is a significant p-value of 0.002. So coming to the discussion, majority of the procedures, that is 2/3 of the procedures, were successfully completed with the single aliquot of sedation without compromising the efficacy of the procedure, especially in settings like outside the operating room. And remaining procedures were successfully sedated with the subsequent doses. The overall adverse events were 33, mostly were mild to moderate, with the exception of one child had desaturation, especially with the third aliquot, and the procedure was aborted. Success rate with the first alicot among underweight children showed only 44% as against the 72% among other children. That is, the underweight children required multiple doses. In contrast, in another study, the underweight children had an increased incidence of adverse effects, but the dosage requirement was similar to the normal weight man children. Coming to the conclusion, in our study, the combination of low-dose sedatives in repeated aliquots based on individual response provides adequate procedural pseudoanalgesia, and there were only very few adverse effects, making this sedation protocol a safe alternative in resource-limited settings. It also demonstrated cost-effectiveness and also avoids delay in providing appropriate treatment. And lastly, undernourished children required more sedation in our study, which needs further confirmation from a larger cohort. So recommendations would be low-dose midazolam and ketamine are found to be safe and effective as pseudoanalgesia in critical care settings outside the operating room with necessary precautions taken. So instead of giving a single bolus dose, repeated aliquots can be given based on the individual response to minimize the incidence of adverse effects. Thank you.
Good paper, good presentation. Question is, how was the sample size of 165 arrived at?
Ma'am, it was
No, did you arrive at the sample size?
yes,
Or that
ma'am.
was what it was possible for you to do?
Yes, ma'am. We compared with the previous study. It was around 165. We also had the sample size of 165, ma'am.
That is not the way. Okay. And you said if the first dose did not produce required analgesia, you will repeat, I mean, between the score of 3 and 4, either midas or ketamine. So, how will you choose between midas and ketamine? How many received midas? How many received ketamine? So, there is heterogeneity in your group.
So if the score was 3 or 4, we gave either midazolam and ketamine. It is based on the clinician's preference, ma'am. So in case if the child have respiratory depression, we prefer to give ketamine rather than midazolam.
But you should have presented the data that how many you gave ketamine, how many you gave midas. Okay. Then in your result again, you have not given the confidence limits, and you are saying that for this up to the second aliquot there were no reactions. Only for the third aliquot there were reaction. So we might and almost 98% required 2 aliquots. So isn't it okay to use the? Why did you choose to use the half dose instead of full dose? So even that could have been okay without adverse event and with good efficacy.
Sorry.
No, with two doses where did not produce adverse event, but it was efficacious. So that your study says that half dose is enough for 2/3. So instead, we can go ahead with the full dose itself.
Only mild side effects was associated with the second alicot, ma'am. But even with the first alicot, most of the children were sedated. So we prefer to choose the 50% of the actual dose, ma'am.
Nowhere in the paper you have mentioned whether it is which route of administration. What is?
Yes, I have mentioned.
No, where did you mention? Whether?
Sir.
Show me a slide where you have seen. At least you tell me whether it is.
Side.
Okay. Where is it? Tell me.
Intravenous.
Potrukka. Oh, I'm sorry then. I just missed that point. What are the other routes that are available?
IM, intranasal.
Okay. You have chosen, the madam also mentioned, a heterogeneous group of patients from 1 year to 17 years. So definitely different children behave differently. Another thing is the procedures you are also used also, there is no uniformity starting from bone marrow to say CSF analysis you have mentioned. Because the pain tolerance will be different in different age groups. Pain is also different in different procedures. Pain also based on the disease of the patient, the child is suffering from. And who observed all those things?
So the pediatrician and the staff nurse, sir.
Is it the same pediatrician or same nurse, or they will be changing duties, no? There will be inter-observer variability, no? Or was there any independent observer? You could have an independent observer also, if you have a data on a case sheet.
What does the existing literature on the subject shows? Do you have any earlier studies on this subject?
Yes, sir. There are various studies which have showed low dose repeated aliquots is more better than a single bolus dose.
Why you have not actually projected?
Sorry.
You haven't actually projected the literature review separately. What are the gaps available which made you to go for the study? So you should have actually justified the study. Why did you go for this one? So is it the appropriate study design to go for this?
Yes, sir.
Are you sure?
Yes, sir.
What was the existing this one practice earlier in your institution?
Previously, 1 mg per kg of ketamine and 0.1 mg per kg of midazolam were administered.
So you are having the same thing followed. Now you have
We have
some
changed.
dose as a dose only actually changing.
Yes,
You
sir.
were already practicing this one.
Yes, sir.
So that should have been brought in the objective as this one. We are testing the dosage. It is not the entire efficacy of that particular drug combination, right? Then was there any blinding done between the administered those person who was administered and those who have actually observed the outcome?
No, sir.
So if it is so, what is the ideal study design? It should have been a
RCT.
clinical trial, at least randomized control trial, maybe blinding if possible. I don't know how far it is possible in this one. Then in the results, you have actually in the analysis you have told about the weight, whether it is able to modify the outcome, right? So there will be some many other factors which may be influencing out apart from the intervention studied. Have you actually compared the baseline characteristics with those things, whatever this? So in a study like this, you should have actually projected first result slide should have been a baseline comparability. Whichever factor we think they are going to influence, we should have actually compared. Then only you can attribute whatever effect we have found out to the particular intervention which is being studied, right? Otherwise, it was actually the results and other thing was nicely projected. All the best, ma.
Thank you.
Thank
sir.
you.
Thank you.
Thank you, Dr. Abhinaya, and thank you, judges. The next presenter is Dr. V.K. Ashwini, lung ultrasound in prognosticating community acquired pneumonia.
A very good morning to one and all present here. I'm Dr. Ashwini VK, here to present my paper on lung ultrasound in prognosticating community acquired pneumonia. First of all, at the outset, I would like to thank IAP TNSC and the South Zone Pedicon for giving me the opportunity to present my paper on this prestigious platform. As we all know, community acquired pneumonia is one of the leading causes of death among children under the age of 5 years. It poses a significant burden on the healthcare system. Lung ultrasound is an ionizing radiation-free imaging modality that has gained recognition in the diagnosis of respiratory illness. The different patterns on imaging correspond to varying degrees of aeration loss. Lung ultrasound score has been used in the adult critical care setting to quantify lung aeration. However, the studies in the pediatrics is limited. There are studies available in the neonatal age group where lung ultrasound score has been used for predicting extubation failure and surfactant therapy. So as a part of my study, my objective was to assess the utility of lung ultrasound in prognostication of community-acquired pneumonia. As a secondary object, I compared and correlated the different scoring systems available. These are the clinical respiratory score, the Brixia score based on the chest X-ray, and the lung ultrasound score to predict outcomes of clinical interest. The three outcomes being escalated care, duration of antibiotic, and duration of hospital stay. Escalated care was the need for any ventilatory requirement, either invasive or non-invasive, within 24 hours of admission. Duration of antibiotic cutoff was taken as 10 days, and duration of hospital stay was taken as 7 days. To brief about the clinical score, the scoring system, clinical respiratory score takes into account 6 clinical parameters. The chest X-ray score, known as the Brixia score, divides each lung field into 3 zones with a score of 0 to 3 in each zone. Lung ultrasound score divides each lung field into 6 zones with a score of 0 to 3 for each zone. The following images depict the zones for scoring based on imaging. The initial one shows the chest X-ray where the lung field is divided into the upper zone, the middle zone, and the lower zone. The next image shows the lung ultrasound imaging zones, that is anterior, superior, and inferior, lateral, superior, and inferior, and posterior, superior, and inferior. This image depicts the normal scoring system for based on chest X-ray, which is the Brixia scoring. Score 0 for a normal chest X-ray finding, score 1 for interstitial changes, score 2 for non-confluent airspace opacification, and score 3 for confluent consolidation. Based on lung ultrasound imaging, score 0 for normal pattern, score 1 for well-defined B pattern with 3 or more B lines, score 2 for severe B pattern with subpleural consolidation, and score 3 for lung consolidation. This was a prospective observational study conducted in a tertiary care pediatric center in Chennai with a study duration of 7 months from November 2022 to May 2023 with a sample size of 44. We included children between the age of 1 month to 18 years with a clinical diagnosis of pneumonia. Clinical diagnosis of pneumonia was based on the WHO criteria, which takes into account fever, fast breathing, and chest indrawing. Fast breathing cutoffs appropriate for age was taken into consideration. We excluded children who were being treated for tuberculosis, those with congenital heart disease, chronic lung disease, immunocompromised children, neuromuscular disorders affecting the lung musculature, ventilator and hospital acquired pneumonia, and chemical pneumonitis. As per the study protocol, relevant demographic and clinical data were recorded in an Excel sheet. The clinical respiratory score was recorded at first assessment and was used to assess the severity. Chest X-ray and lung ultrasound was done within 24 hours of admission to the hospital. Lung ultrasound was performed by a pediatric radiologist and the score recorded. She was blinded to the clinical parameters and was unaware of the chest X-ray findings. The attending physician was unaware of the total lung ultrasound score. The total lung ultrasound score was not used to guide escalated care and hence not recorded in the patient files. For the statistical analysis, we sought for the association between two qualitative variables using the Fisher's exact test. Students' parametric t-test was used for independent groups. Jordan index was used to calculate the cutoffs based on the scores. The correlation between the different scoring systems was computed using the Pearson correlation, and overall, the data analysis was performed using the IBM SPSS statistic version 27. Our results were as follows. 44 children were enrolled with a clinical diagnosis of community-acquired pneumonia, of whom 53% affected were girls. The mean age of the affected population was found to be 5 years. 86% of the affected children were immunized appropriately for age. Only 13%, however, had received the pneumococcal vaccine. Coming to detection of consolidation on chest X-ray versus lung ultrasound, it was found that there was equal sensitivity by a chest X-ray and lung ultrasound corresponding to 93%. However, lung ultrasound outperformed chest X-ray in detection of consolidation since it had a better positive likelihood ratio and accuracy. Detection of pleural effusion on lung ultrasound was better, as 9 cases that were missed on a chest X-ray could be picked up on a lung ultrasound. Similarly, 1 case of collapse that was missed on a chest X-ray was picked up on a lung ultrasound because it corresponds to different degrees of aeration loss. Additional findings that we could make out on a lung ultrasound were features of necrosis and pneumonia, loculations and septations, which are characteristics of pleural fluid. So coming to whether a lung ultrasound score predicts the need for escalated care. 12% of the children affected with pneumonia in our study required escalated care in the form of some oxygen requirement. 13% required surgical intervention in the form of either ICD drainage or a thoracotomy. As is evident from the 95% confidence interval graph, where we have compared the different scores, mean lung ultrasound score for escalated care was found to be 4.55 against 4.52 for those not requiring escalated care. There is no significant difference in these two scores, and as is evident from the area under the curve graphs, the lung ultrasound score area was only 0.5, which is not significant. Does lung ultrasound score predict prolonged hospital stay? So 29% of the population, children affected with pneumonia required hospitalization longer than 7 days. The mean lung ultrasound score for a longer hospital stay was 6.15 as against 3.84 with a significant p-value. Best cutoff value that we could arrive based on this was 2.5 with a 100% sensitivity. This is to say that with a lung ultrasound score of 2.5, 100% of the affected children required prolonged hospital stay. Coming to the area under the curve graphs for the same, it is comparable with CRS with an area under the curve of 0.7, which is statistically significant at 95% confidence interval. So does lung ultrasound score predict longer duration of antibiotic? The score was 3.86 for shorter duration of antibiotic versus 5.89 for a longer duration of antibiotic with a significant p-value of 0.02. The best cutoff value that we could arrive based on this was 2.5 with a 100% sensitivity. Again, the area under the curve based on the lung ultrasound score was comparable with the clinical respiratory score at 0.7 and was found to be statistically significant at 95% confidence interval. Considering the correlation based on the Pearson correlation between the 3 scoring systems, we found a linear correlation amongst the 3 scoring systems. So to summarize, lung ultrasound is more sensitive than chest X-ray in detecting consolidation, pleural effusion and collapse. Necrosis and character of the pleural effusion are delineated on an ultrasound, while it could not be delineated on a chest X-ray. Lung ultrasound is useful to predict prolonged hospital stay and prolonged duration of antibiotic, but it could not predict the need for an escalated care. I repeat, lung ultrasound score could not predict the need for an escalated care. Linear correlation exists between all the three scoring systems. The limitations of my study is that the sample size is small, with only a sample size of 44 taken. This was due to 24/7 unavailability of the pediatric radiologist who was required to perform the lung ultrasound. Day of presentation of the illness has not been taken into account, and this is the limitation because the imaging findings will vary based on the presentation of illness. Future prospects include formation of a composite integrated score taking into account lung ultrasound score and the clinical respiratory score to predict the same outcomes. Thank you.
You have chosen the prime indicator as a Uden index, no? And
Sorry.
you have looked Uden index, you have taken it
Yes,
as this one for assess the cutoff value, which is optimal. So it has sensitivity as well as specificity without actually much of false positives and false negatives.
Yes, sir.
Why you have chosen Uden index over area under curve? If I remember correct, you have not concentrated, you were actually repeatedly saying about the area under curve, and you have not told about the Uden index. What is this Uden index?
Uden index is based on the receiver operating curve only, sir, where sensitivity by 1 minus specificity is taken into account. It is based on that curve only, but the cutoff value we arrive based on some formula. This formula, the sensitivity by 1 minus specificity, comparing all the patients for whom the score is given, gives a value cutoff of 2.5.
What is the definition you have used for community acquired pneumonia?
I have taken WHO guidelines for defining pneumonia, sir, where fever, fast breathing, and or chest indrawing. That is the definition used in resource limited settings, but that itself has been taken
With
into account.
X-ray confirmation or without X-ray confirmation?
Without X-ray confirmation, only clinical
So
criteria
only
has been
clinical
used.
criteria
Yes,
has been used. Thank you, ma'am.
You have done this ultrasound only for prognosticating or also for diagnosis?
only for prognosticating
In all your patients, you have done both ultrasound as
and
well
chest
as
X-ray. Yes, sir.
Normally, which is the first one you are doing, and how long it takes after patient? It's only an outpatient setting or inpatient?
It's an inpatient study, sir, within 24 hours of admission. So if the radiologist is available within 24 hours of hospitalization of the child, the lung ultrasound has been done. For those whom it was done on maybe day 2 or day 3 of hospitalization, they were excluded from this study. Chest X-ray was possible to be done on a faster basis because we could mobilize the child. It did not require any clinician to be there. Just the technician needed to be there and we could shift the child. But on a Sunday, on a government holiday, when a pediatric radiologist was unavailable, we could not perform the lung ultrasound.
So all the ultrasound were done by pediatric radiologists.
It was done by the
only.
same pediatric radiologist so that we could avoid a bias.
What is the sensitivity and specificity of diagnosis with ultrasound? Pneumonia, community acquired pneumonias.
As per my study, the sensitivity comes to 93%, sir. Based on reference study, it is anywhere between 95 to 97%.
In your objectives, you have mentioned that this can be used for indicating extubation failure and surfactant therapy. Can you explain that?
Studies are available in the neonatal age group where lung ultrasound score done on day 1 of hospitalization and subsequent hospitalization is used to predict extubation failure. But that is neonatal age group, which is not my reference population for this study, sir.
It's a good study.
Thank you, sir.
What is your study design?
It's a prospective observational study, ma'am.
Isn't it an evaluation of diagnostic test? What is the index test you are evaluating? What is the gold standard?
Gold standard we have kept for diagnosis of pneumonia as chest X-ray itself because there has not been any other imaging
You are
modality done.
evaluating a diagnostic test. So which is your index test? You are comparing it with what?
I have compared both the imaging modalities with the clinical parameter. That is a clinical diagnosis of pneumonia, not any specific imaging test.
Okay. You said clinical parameter, independent physician, and lung ultrasound independent. Who was the one who interpreted the X-ray?
Chest X-ray was also interpreted by the pediatric radiologist, but she was not aware of which patient's X-ray it was, whether it was the same for whom an ultrasound had been done.
That should have been mentioned. That was not mentioned.
Yes, ma'am.
And how was your sample size arrived at?
Sample size was based on the prevalence of pneumonia in our population.
That is wrong. Sample size should be based on your objective, not on prevalence of the condition.
Okay, ma'am.
And so what do you recommend? How useful is ultrasound? For what sense? And
Lung
what does it cost? Is it really useful?
Lung ultrasound, I would say, is cost effective because there is repeatability. We just need money for installation of the machine, but once trained, it can be repeated at different times to see how the progression of the disease is. Unlike chest
But
X-ray,
what is the shortcoming?
there has to be a trained person to be able to
It
perform
is
the
based on
ultrasound.
the skill of the person. It cannot be replicated everywhere. What is the fallacy of having a clinical definition of community acquired pneumonia?
It is not a fixed definition, and we may confuse with other similar respiratory illness
There
like
should have been a
bronchiolitis.
large chunk of visas who would have come under this community acquired pneumonia.
Yes, ma'am.
So how many were actually visas who had come under this definition in your study?
That I have not taken into account, ma'am. I have not considered those. Only at the initial assessment, if a clinical diagnosis of community acquired pneumonia has been
All
made,
this should
it
have
has-
been mentioned as limitations.
Okay, ma'am.
Thank you.
Thank you, ma'am.
Thank you, Dr. Ashwini, and thank you, judges. The next presenter is Dr. Sherin Farhana, comparative study of procalcitonin versus septic screen parameters in early diagnosis of neonatal sepsis.
Good morning, everyone. I would like to thank IAP for giving me this golden opportunity. I thank our respective judges. My study is on comparative study of procalcitonin versus septic screen parameters in early diagnosis of neonatal sepsis. As we all know, infant mortality rate is a surrogate marker of a health system of a society. According to Register General of India, IMR has declined from 44 to 28 deaths in the last decade. In contrast, NMR has declined only from 30 to 25 deaths in the last year. NMR is a major contributor for IMR. Neonatal care has been improved in the last year all over the country by strengthening special newborn care unit in medical colleges and newborn stabilization unit in government hospitals. In spite of the above measures, NMR couldn't be reduced. Most common causes are being prematurity and sepsis. While various modalities including ventilator availability, surfactant administration, human milk bank are being practiced to improve clinical outcome of a preterm baby, due to their inevitable prolonged SNCU stay, they become vulnerable to sepsis. Until now, there is no ideal diagnostic test for detecting sepsis. Blood culture, even though considered as gold standard, its high false negative rate and delay in obtaining results place a limitation on its clinical utility. Common septic screen parameters practiced are total leukocyte count, C-reactive protein, microerythrocyte sedimentation rate, immature to total neutrophil ratio, and absolute neutrophil count. These indices do not have high sensitivity and specificity, leading to untoward complications, prolonged SNCU stay, and increased cost burden. CRP is an acute phase protein produced in liver in response to infection and inflammation. It is one of the widely used laboratory tests in sepsis. Recent studies have focused on the use of biomarkers in early diagnosis. One such evolving biomarker is procalcitonin. It allows in faster diagnosis in sepsis. Lot of studies on procalcitonin is being done on children and adults with minimal in newborn. Our objective is to compare and analyze the accuracy of procalcitonin versus septic screen parameters, including CRP, in diagnosis of sepsis. It is a prospective observational study conducted in a newborn care unit of a tertiary care center. Study period is from May 22 to April 23. Inclusion criteria: neonates admitted with clinical signs and symptoms suggestive of sepsis, including maternal risk factors, refusal of feeds, temperature instability, altered sensorium, low blood sugar levels, need for oxygenation. Exclusion criteria: neonates admitted to other causes, meconium aspiration, birth asphyxia, RDS, IEM, and major congenital anomalies, neonates who had prior antibiotic exposure. Methodology: specimens of blood was obtained for blood culture, sugar, calcium, septic screen parameters, procalcitonin, C-reactive protein, chest X-ray, and CSF analysis. Newborn were treated with warmer care, IV fluids, appropriate antibiotics, and ventilatory support. Serum procalcitonin is measured using ichrome procalcitonin, which is a fluorescence immunoassay technique. Values of less than 0.5 nanogram per ml rules out infection, 2 to 10 nanogram per ml suggestive of sepsis, and more than 10 nanogram per ml suggestive of severe sepsis or shock. CRP was measured using immunoturbidometric method. Value more than 6 mg per liter is considered positive. ANC was plotted using Mosino and Monroe's chart, and immature to total neutrophil ratio was obtained from peripheral smear. Statistical analysis: correlation between serum procalcitonin and septic screen parameters were analyzed and compared using sensitivity, specificity, positive and negative predictive value, positive and negative likelihood ratio. Ethical committee approval obtained and parental consent obtained. Our total was 320 cases. In that, Child meeting exclusion criteria were excluded, and in remaining clinical sepsis, 240 cases, we subjected them to all septic screen parameters, in which culture positive sepsis turned out to be only in 20% of the cases, and the remaining culture negative sepsis turned out to be 80%. This is a demographic profile of neonates admitted in sepsis. Our study has major preponderance in male category, early preterm, late preterm, and low birth weight babies, and we were also had major preponderance in early onset sepsis group. Blood culture positive was in 20% of cases and it was negative in 80% of cases. Correlation of procal with septic screen parameters. In 216 clinical cases, procalcitonin was able to pick up 90% of neonates, and in culture positive, it was able to pick up 100%. Whereas in culture negative group, which was in all other septic parameters were negative, procalcitonin was able to pick up 87.50% cases at an earlier stage, so we could start appropriate antibiotics earlier and prevent mortality and morbidity in these neonates. In contrast, CRP was elevated in 40 and 50% of cases, and other septic screen parameters were elevated only in negligible amounts. In early onset sepsis, procalcitonin was positive in 91.5 in contrast to CRP, which was 36.2%. In late onset sepsis, it was 84.6 and in CRP was 61.5% of cases. Other findings were elevated only in negligible cases. So we also followed up the child after 24 hours of antibiotic treatment. Fall in procalcitonin was observed in 91%, whereas CRP is 20%. So sensitivity and specificity of procal was 90 and 95%, in contrast to CRP, which was 41.67 and 65%. Positive predictive value was 98% and negative was 76%, in contrast to CRP, which was 78% and 27%. Major organism isolated was cons, followed by Klebsiella and Pseudomonas. So this bar shows a culture negative sepsis group, 192 children, where all other septic parameters were missed, and procalcitonin was able to pick up this at an earlier stage and helped in appropriate antibiotic therapy. Discussion. Neonates admitted for scenarios other than sepsis acquire secondary sepsis due to multiple intervention procedure. So these septic screen parameters, which are highly non-specific, being elevated in other conditions such as meconium aspiration, RDS and birth asphyxia, thus giving false positive and negative results. So in this scenario, overdiagnosis leads to drug toxicity, secondary fungal invasion, whereas underdiagnosis, they may succumb to complications such as sepsis, DIVC, shock. So accurate and early diagnosis is mandatory. We here see the comparison between CRP and procalcitonin. CRP rises within 36 to 50 hours following an insult, whereas procalcitonin rises immediately within 3 to 4 hours after insult. Also in CRP, maximum level is reached within 24 to 48 hours, whereas in procal, it reaches within 6 hours. It is highly non-specific, whereas procalcitonin is downregulated in viral infection by interferon gamma. So total leukocyte count was elevated only in 20% of cases, and ESR and IT ratio was abnormal in 3.3% of cases. These ratios, due to subjective variation and practical difficulties, are not followed in many setups. In our study, sensitivity of culture positive sepsis, procal picked up all 100% of cases, and in culture negative sepsis, it picked up 87.50% of cases. This is supported by the positive and negative likelihood ratio of procalcitonin. In early onset sepsis, sensitivity is 91.5 and in late onset it was 84.6%. In various gestational age, procalcitonin picked up all neonates in extreme preterm group and 90% in preterm and 85.7% in term. Sensitivity was 90% in compared to which was 41.67%. This is supported by the study done by Susila Thangam. So positive likelihood ratio of 18 and confidence limit of 95 suggests that if procal is positive, the probability of having sepsis is 18 times higher than a person whose procal is negative. Similarly, negative likelihood ratio of 0.11 suggests if procal is negative, probability of having sepsis is less. Accuracy was 91.25 in compared to CRP, which was 47.5. Hence, it is statistically significant, avoiding overdiagnosis and underdiagnosis. Also helps in reducing the cost and emergence of bacterial resistance. Procal in response to antibiotics, fall was 91%, whereas in CRP it was 20%. Hence, employed in prognosis of sepsis also. It's a sensitive and specific biomarker with good positive and negative likelihood ratio. Though the cost of the kit is high, it is negligible when compared to the cost burden of antibiotic usage, drug toxicity, essence use stay, inotrope usage, blood products, long-term morbidity of the neonate, and mental agony to the parents. Ours is a single center study, but we are able to overcome this by including neonates in all possible categories, and repeat investigation were done to prognosticate. Conclusion: procalcitonin is a good biomarker to diagnose all forms of sepsis irrespective of gestational age. Culture results: sensitivity, specificity, positive and negative predictive value, positive and negative likelihood ratio was statistically better when compared to other septic screen markers. Whenever an investigation is available, it is preferable to include it for the betterment of neonatal outcome, thereby reducing the NMR and IMR of our country. Thank you.
What about the existing literature on procalcitonin?
Many studies are available in children and in adults, ma'am. ICU setup in inflammatory conditions, whereas in neonates, many minimal studies are available. And in these
Neonates,
studies,
minimal studies are available.
ma'am, compared to adult age group, ma'am.
No.
Adult and
Aren't
children.
there good study? What is the new thing? Because whatever you said has been already proved in studies. What new evidence have you created from your studies?
Even though it is available, ma'am, it is not routinely practiced in all
May
setups,
or may
ma'am.
not be routinely practiced due to different reasons. But what new finding you have made? Whatever you said is already available in the existing literature. There is no gap. Nothing new you have found out from your study. So all this is available, already known. So what is the new thing which you have found out from your study?
Ma'am, we did this to implement it in routine practice to include it in one of the marker in septic screen parameters, ma'am. Instead of routinely following
No,
leukocyte
doctor, all
count,
evidence is already available. What is the gold standard you have taken?
blood culture, ma'am.
Blood culture.
According to literature, blood culture is a gold standard test.
No, I
Yes,
am
ma'am.
asking, you have given sensitivity, specificity, PPV, NPV. For that, which is the gold standard you have considered?
We compared it with all septic screen parameters, ma'am, including CRP.
Then what is the index test? Your index test is procalcitonin.
Yes, ma'am.
Then if you are going to compare it with that, what is your gold standard? I am asking. You are giving the sensitivity, specificity of both. So you are comparing these both against what gold standard? Against culture or against clinical
Against
criteria?
blood culture, ma'am. Culture negative group, we were able to pick up all these sepsis category
Then how
because
you can
of.
give the sensitivity, specificity in culture negative group? You don't understand my question at all, or you don't understand the methodology. What was your gold standard to calculate the sensitivity, specificity?
Ma'am, we compared procalcitonin with septic screen parameters, ma'am, including CRP, IT ratio, and absolute neutrophil count.
I'm asking the same question in a different way. What is the reason for such a low sensitivity? I mean, culture report, only 20% you said
Yes, sir.
positive. What do you think the reasons for so much of not picking up in the culture?
So, taking blood prior to antibiotic exposure or amount of sample taken, culture broth ratio, due to various practical difficulties, this could have been missed, sir.
No, we assume only the gold standard is still the culture.
Yes,
So
sir.
you cannot say this is superior over that, or it is a definite positive predictive value is more.
Yes, sir.
Are you doing this procalcitonin test in all the babies?
Sir?
Yeah. In all the babies admitted in your units suspected neonatal sepsis?
Yes, sir. So, I couldn't understand your questions.
No, did you do procalcitonin test
In all sepsis, clinical sepsis group,
at
sir.
the time of admission itself?
Yes, sir.
Or when there is a progression of the
No, sir.
improvement?
When we suspected they had clinical signs and symptoms suggestive of sepsis, we took them for sepsis screening workup, sir.
What's the cost of this procalcitonin test?
So 700, sir.
So what is your final recommendation?
Implementing it in one of the septic screen parameters will help to pick up sepsis earlier, identify the illness severity of sepsis, and in escalating antibiotics at an earlier stage, sir.
So repeatedly everybody was asking about the gold standard. No, you were actually not clearly stated the gold standard. Right? That's where the problem is. And you have used one component of this one separately, WBC and indices,
Yes,
no,
sir.
separately. So that one only has actually created the problem in the projection. And only one thing I have. What are all the cutoffs you have got it for CRP? Cutoffs normal to
6 gram per liter. 6.
Is it actually universally accepted? What about the other?
No, sir. According to each lab, it varies. In my lab, this was the cutoff limit, sir.
Cutoff.
Yes, sir.
Could have been actually better if you would have actually analyzed that also with various cutoffs.
Yes.
Maybe that suggestion alone I have.
Oh, yes,
Wish
sir.
you all the best.
Yes, sir. Thank you, sir.
Thank you. I thank the presenter. Thank you, judges. So that brings us to the end of the reputed Dr. C. Thirugnanasambandam Award. I request the office bearers of IAP Tamil Nadu to honor the esteemed judges for judging this prestigious award of South Zone Pedicon. I also request the office bearers to honor the judges of the poster presentation of yesterday, Dr. J. Balasubramaniam, Dr. E. Shivakumar, and Dr. Murugesa Lakshmanan. Thank you again. We now have the scientific session of the day. May I now invite teacher of teachers, Professor Dr. T.L. Ratnakumari to chair the session. Professor T.L. Ratnakumari was the professor and head Department of Neonatology at Institute of Child Health and Obstetrics, Egmore, and formerly professor and head of ANIMS, Andaman and Nicobar.